I'm Joseph Foderaro, a clinical social worker by training. I'm currently with the Center for Nonviolence and Social Justice and Healing Hurt People as a psychoeducational training specialist. And for many years before that, I served very proudly as program director for the Sanctuary programs. Sanctuary programs started off as a small inpatient behavioral health unit that was actually, I believe, one of the first trauma-informed programs in the country. In the process of starting our first trauma-informed program, and those were in the days before that was even a commonly used phrase, we were wondering, myself and my colleagues were wondering what it was about our program that allowed us to have a different type of relationships with our clients. We found that people were coming to Upper Bucks County from a number of different places we thought were unlikely, such as Bermuda, Philadelphia, and other locales far removed from Quakertown, Pennsylvania. And we were trying to understand what it was about our programs that made the program at Quakertown Hospital a little bit different. I think there were two different types of circumstances that allowed for us to see the import of trauma in the histories of the people we were serving. First and foremost, in the process of establishing relationships with our clients at Quakertown Hospital, we found it necessary to really enlist the participation of our clients in the treatment process. We believed that it was important to have our behavioral health unit have open doors, unlocked doors, and as such, we needed the participation, the active participation of all of our clients. So we began right from the get-go of establishing a different type of relationship with our clients at the time. We did that by essentially enlisting their help and cooperation in getting more of a sense of what the treatment might be for their stay at Quakertown Hospital in the Sanctuary program. We did that by essentially changing the type of interview we did from, in so many words, asking the question, what's wrong, or what were the problems that brought you here, to asking clients coming to Quakertown Hospital in the Sanctuary program, what happened that brought you here to Quakertown? And we found that by asking the question, what happened to a person, we elicited a number of different types of responses that weren't drawn from the individual when we asked them what was wrong. There were actually 3 different people on our unit at the same time that brought to the forefront the realization and the appreciation of the impact of trauma. We had a young adolescent who was on our program who was suffering from a severe eating disorder. We had a middle-aged person who had attempted suicide by gunshot wound, and she barely made it through that event, but she was also admitted on our program. And we also had a senior citizen who was trying to find some sort of security and some sort of peace from some delusions and some hallucinations that were tormenting him. And in the process of asking the question, what happened, we found that the 3 of those individuals actually shared a common history of trauma, which allowed us to actually develop some treatment interventions that made sense for all 3 of those individuals at the same time. It made the approach much more personable, number one, much more impersonal. It seemed to permit a different type of relationship with our clients that we did not have when we were just trying to address the symptoms of the individual as they presented to the program. It felt that we were engaged in a much more active and collaborative relationship with our clients, and it felt much more productive. And knowing the details of a person's story allowed us to be more creative as we tried to engineer different types of interventions and responses for those individuals. We were humbled by the enormity of the details of the stories that were facing us. So we discovered that rather than approaching individuals and their individual stories as individual clinicians, we really encouraged the development of a community of peers, a community of clients, and a community of staff where we all felt the collective strength and security of each other, being part of a collective experience rather than a number of individuals working on individual problems. Social support was probably the key element of the original sanctuary programs and the mechanisms by which a person can build community. It feels like I've been involved in a number of different initiatives and attempts made to bring trauma-informed care to the city of Philadelphia almost right from the very beginning. I remember being involved with doing S.E.L.F. groups for individual shelters and rehabilitation programs in the city. And in those days, they were mostly just individual groups for a group of 8 or 9, perhaps mothers at the time, going through treatment programs. And it was always exciting to watch how a S.E.L.F. group might be really an effective way of bringing trauma-informed constructs to women and their children who perhaps never heard of issues about dissociation and trauma responses before in the course of their treatment or rehabilitation. In the course of doing these individual groups with individual programs, it seemed that there were more and more programs that were interested in doing S.E.L.F. groups, and this expanded our ability to do groups throughout the city. In the process of doing groups, because I believe that S.E.L.F. groups and trauma-informed care actually promote stronger and more cohesive communities, we also found that in addition to earning I believe, the respect and the trust of the clients with whom we were working, a large number of staff of these programs also showed an interest in S.E.L.F. and in trauma-informed care. And I think those were the beginning days of building up some clinical momentum for trauma-informed care in the city. I believe fundamentally that trauma has the potential to fragment communities. I've also seen how trauma and trauma-informed care has the ability to bring fragmented communities back together again. And under the umbrella of trauma-informed care, I've seen disparate communities of helpers, be they substance abuse or chemical dependency programs, homeless shelters, behavioral health centers, violence intervention programs. I've seen how a trauma-informed umbrella actually promotes greater levels of understanding and cooperation among disparate organizations and helpers. I think anytime a helper goes into a system, whether it's a family system, an organizational system, or community, or even an individual and their own internal system, I believe that anytime a helper enters into a system in an effort to bring trauma-informed care and perspectives to that individual or that system, it seems to, I've noted, at a certain point, promote, maybe a better word might be provoke, almost an autoimmune response that creates an opportunity for the person to either approach an intersection to let go in the S.E.L.F. model, to let go of old patterns and old coping mechanisms and move on, or sometimes reflexively, I believe, a person tends to hold on more tightly to old and established ways. So there almost seems to be an autoimmune response to bringing a cultural shift to an organization. It can be successfully addressed, but it can be a little discouraging at times. I've found support from individual clients going through the individual programs they are in their recovery process. I've seen support from line staff who themselves might be most acutely aware of the details of an individual's journey, and I've received amazing levels of support from management and upper levels of administration in the city of Philadelphia. Some of this change is really best noted whenever I find myself in the process of having an opportunity to do a teaching or training for students or for other organizations in the city of Philadelphia. I find that almost every 6 months I have to review all of my material because the level of awareness and the level of sophistication amongst the students or the trainees in the program with which I'm involved, the level of awareness seems to be increasing over a period of time, and that's nothing but a really good sign. I think a two-prong approach is really helpful. I like the idea of bringing trauma-informed care and the constructs of trauma-informed care to the participants of programs themselves directly, because while I believe organizational change also comes from the top and gets transferred through the rest of the organization, I believe it's nothing like an informed population or an informed citizenry that holds management to the standards to which that they subscribe. So I like including participants in programs as well as the staff and managers of program simultaneously. First and foremost, don't try doing this by yourself. Creating a shift in culture from a traditional approach towards working with survivors of trauma and adverse conditions into a truly trauma-informed care requires a lot of work, a lot of support, and a lot of community, and is far beyond the capacity of any one individual to do it. You might do your best, but you'll get tired very quickly. So I'm a firm believer in finding as many people as you possibly can from all levels of your organization or from all levels of the community, including the participants of programs, and forming a collective that allows you to do this task together. In the process of doing groups in different kinds of locations, many of which I had never been in before, my background is in outpatient behavioral health services and in inpatient behavioral health services, and I don't have a lot of experience working in homeless shelters, and I don't have a lot of experience working in residential programs for children or for substance abuse. But what I found in the process of starting to do self-groups in these different types of settings was that these settings had much more in common than I originally thought. While they all had their own way of looking at problems and looking at coping mechanisms, what they also had in common was a shared population of trauma and survivors of adverse conditions. And I found that working with these different organizations allowed me to emphasize really literally the strengths of the organizations and the strength-based model of individual approaches towards rehabilitation, rather than just working on the specific nature of the specific problem. They had a lot more in common than I had originally thought, and as it turned out, more than they had originally thought with each other too. We began by doing self-groups with some homeless shelters and residential programs for women in recovery. In the process of doing those groups, we started to build a network of personal relationships as well as professional collaborators. We would get on the phone and talk about the way a self-group might be going in a homeless shelter and the similarities and differences of that self-group as it would present itself to a residential program for women in recovery. As we pointed out the similarities and differences, more and more of the managers and the staff of these different programs started to have conversations with each other in their programs and with their friends and colleagues in other programs, and I think that built up some momentum for trying this approach of bringing self-groups to the different organizations. It seems that the self-group model is a very good way of introducing trauma constructs to a community. And a number of different types of organizations wound up bringing these groups to their programs and really liked the values upon which these groups were based. I believe a necessary next step for public policy in this city would be for there to be a complete and comprehensive inventory of all the individuals and organizations who have had exposure to trauma-informed trainings, trauma-informed teachings, or other types of already funded and already supported mechanisms to bring trauma-informed care to their respective organizations. I think there are many, many people in this city who have been trained already, and we're all doing, I believe, an excellent job of helping the citizens of Philadelphia. But I do think it's time for there to be a pause, a moment of reflection, and for public policy managers to take a look and see just how many people there already are, if you will, in the stable of trauma providers in the city. And with that, there might be even a more effective way of designing future interventions, future trainings, and future ways of incorporating the citizens of the community along with the professionals in the community who have already been trained.